Hello, everyone. This is Ms. Anderson. I'm one of the professors for semester 4, and we're going to do your online activity. So I'm going to share my screen. We are going to do the online activity for gas exchange. So this is what we're looking at right now. Let me move this up here. So what I want you to do is get a piece of paper out. And as we go through this scenario, I want you to write your answers down as to how you would respond. And then I'll go over the answers for this as we're moving through this activity. You can pause it at any time to give yourself as much time as you need to think about this or write it out. So let's jump right into this. It's 7 o'clock in the morning. The day nurse has just received, you're the day nurse, okay? So just keep that in mind. The day nurse has just received the change of shift report about EJ. He's a 26-year-old man who had a ruptured appendix with an emergent appendectomy 2 days ago. He was expected to be discharged today, and your report is as follows. His vital signs: he has a temperature of 101.4. His heart rate's 104, normal sinus tach, regular. He's breathing 28 breaths per minute. He is sitting 90% on room air, has a blood pressure of 100/56. Assessment wise, he has fine crackles in all lung fields bilaterally and a non-productive cough. GI right lower quadrant dressing is clean, dry, and intact. He has bowel sounds in all 4 quadrants ×4. He has some brown purulent drainage from the wound drain, about 20 milliliters. And neurologically, he's alert and oriented ×4 and has been cooperative. He doesn't have any allergies. He's a full code, and he has no pertinent past medical history with an exception of a clavicular fracture from a bicycle accident at age 10. His weight on admission was 72 kilos. He rates his pain as a 2 out of 10 and less medicated with narco, 5/3/25 at 22:30 last night. So about 10:30 last night. He is passing gas, but no BM since the day before admission. He's ambulating independently. The IV's in the left forearm, and it is saline locked with a regular diet. Now, what other questions might you as the RN have for the night shift RN who is providing report? So just pause the presentation for a little bit, write down all the questions that you might have that you'd want to ask the night shift nurse before you begin your shift with EJ. So we'll wait just a little bit while you're jotting these down. Now, there's a couple of things that I would ask. First of all, I would ask if he's received any acetaminophen for his fever. Is he experiencing any shaking, chills, or body aches? Is the healthcare provider aware that he spiked this fever because he was supposed to go home? Do we have any orders for cultures, blood, wound, drainage, or sputum, if obtainable, and urine? What was his urine output for the shift? And how much has the drain put out for the entire shift? Was there a chest x-ray ordered or any orders for oxygen therapy, and any pertinent labs this morning, particularly his white blood cell count? Those are some of the things that I might ask or go to prior to finishing report for this patient. Okay, let's see if I can go. Okay, well, shoot. Okay, I think, do we go? Yeah, there we go. Sorry, guys. So the healthcare provider's on the unit. He examines EJ, and the following prescriptions have been entered into that. That's supposed to be EHR, not HER. Don't you love autocorrect? Electronic health record. So new orders or prescriptions: cancel today's discharge, get a stat chest x-ray, stat arterial blood gas, begin oxygen therapy, and titrate for SpO2 greater or equal to 94%. Obtain cultures, blood ×2, urine, wound drainage, and sputum now. Begin 9% normal saline, continuous infusion at 75 milliliters an hour. Vancomycin 1 gram into 50 mLs of normal saline, IV piggyback every 12 hours. Ceftriaxone 1 gram and 100 mLs normal saline IV piggyback every 12 hours. These are his current lab results. His white count is 16,000 this morning. 85% neutrophils, 18% bands. H&H is 14 and 38. Platelets are 320,000. All his electrolytes are what you see here. So when you look at his assessment, his cues on the previous one, and then you look at his lab results, what's your greatest concern at this time? Yeah, and the greatest concern is this time is his respiratory status, because his O2 sat is low. That suggests hypoxia. So we would definitely want to be pretty aggressive in starting him on some oxygen therapy. So what other orders might you request from the healthcare provider, since he or she's on the unit right now? And one of the things we might normally get in addition to this is a procalcitonin level. Now, looking at those labs, what do they represent and what's of concern to you? The WBCs of 16,000 with 18% bands and the neutrophils being elevated all suggest an acute infection. And what type of infection do we think he probably has? If you answered peritonitis, you would be correct. We might have either a peritonitis, or we might just have an intra-abdominal abscess, which are very frequent complications after a ruptured appendix. Now, looking at these orders, which ones would you implement first? So I'm going to give you a few minutes here. Put me on pause. Okay, so what would you do first? Well, because we're concerned about his O2 sat being low and hypoxia, we're going to start him on the O2 via nasal cannula and titrate per order. We're going to go ahead and put a call out to the lab to get those stat blood cultures. We'll go ahead and ask the tech to obtain a urine the next time he voids, so we can send that for culture, make sure the patient knows that he needs to save his urine, obtain a culture of the wound drainage, and then if he ever coughs anything up, then we'll obviously send a sputum as well. We're going to call for that stat chest x-ray and ABG. Radiology will do the chest x-ray. Respiratory therapy routinely does the blood gases. We're going to go ahead and we're going to initiate his IV fluids at the normal saline at 75 milliliters an hour. And then once we get those blood cultures and wound cultures obtained, because those are the ones that we're worried about the most, may be a little while before we get the urine, but let's get the blood cultures first, because we are going to be worried about what other complication here. We already have SIRS, but he could also get septic from this. So we're going to go ahead and start those vancomycin and ceftriaxone once we get the blood cultures and that wound culture. If we have to wait more than 45 minutes for the blood cultures, then we would go ahead and start the antibiotics, because we want to get those done within the first hour. So which one would you start first, the ceftriaxone or the vancomycin? Think about that for just a minute, and why. If you said ceftriaxone first, you would be correct, because that one's going to run in over about an hour. So vancomycin usually takes anywhere from an hour to 2 hours. So we would want to go ahead and give the one that would go in first quickly. And then again, want to always confirm that he does indeed have no allergies, and that we're going to tell him that if he feels any different than he feels right now, to call us into the room quickly, just to make sure he's not having any kind of reaction to either one of these antibiotics. Both are very broad spectrum, and both are going to work on the bacteria that are most likely to be found either in that intra-abdominal abscess or if he's developing peritonitis, more than likely an intra-abdominal abscess. And then, of course, we have to explain to the patient that his discharge has been canceled and why. So how might you explain that to him? Pause me for just a minute and write this down. Okay, we're going to tell him, EJ, I hate to tell you this, buddy, but your discharge has been canceled. The physicians are concerned that you've spiked a fever and that you still have drainage that looks rather purulent coming from your drain, and your white count's elevated. Because of that, we've got a lot of stuff that we need to do. You're not exchanging your oxygen and your carbon dioxide as well in your lungs, and we're concerned about that. So we're going to start you on some oxygen. We're going to encourage you to use your incentive spirometer 10 times every hour while you're awake. And then we would demonstrate to him how to do that and explain to him the medication that he's going to receive, and that we're going to keep a little bit closer eye on him. But right now, with this white count being elevated and everything, it's just safer if we keep him in the hospital at this time. Now, 7:30 rolls around. These are your blood gases on 2 liters per minute nasal cannula, and this is his stat chest x-ray. So blood gases, you got a pH of 7.46. You got a PaO2 of 78, PaCO2 of 32, bicarbs 23, and your SAT is 88%. So interpret those real quick. Just pause. And your ABGs will show an uncompensated respiratory alkalosis with mild hypoxia. This is remember, this is what we see first when people start to deteriorate. And it tells us that he's got fluid in his alveoli. This is what's causing him to be hypoxic. And in response to that, remember, he's tachypnic. He's breathing about 28 times per minute. He's blowing off his CO2. And right now, the kidneys have not had the chance to compensate for his alkalotic state. So this is something that we would expect early on. Now, when we look at his chest x-ray, obviously we don't ask you guys to interpret this, but he's showing bilateral infiltrates, which again tells us that he's got some non-cardiogenic pulmonary edema. This means the left ventricle is working fine. This is fluid that's leaking in from the capillaries until the alveoli because of increased capillary permeability. And remember, the number one complication of sepsis is acute respiratory failure, and we worry about going into adult respiratory distress syndrome. So we're going to be watching him very closely because this chest x-ray is abnormal. Okay, 7:35. Upon entering the room, he asked what's going on. I thought I was going home today. We already talked about that. So you'd have to go through and explain everything to him. At 10 o'clock, both antibiotics have infused per prescription. Vital signs are now, his temperature is 100.2 after 650 milligrams of acetaminophen, PO at 8. His heart rate still tachycardic. Normal sinus tach, regular. His blood pressure is 98/56. His respiratory rate is 30 breaths per minute. He's still sitting at 88% on 4 liters, and he's using accessory muscles. He is agitated, but still cooperative. So what's your next nursing actions, if any? So pause this for just a minute and write down what your next actions would be. Okay, so as the RN, your analysis of the situation is that he's deteriorating from a respiratory standpoint. He is agitated. That's often an early sign of decreased oxygen delivery to the brain. His respiratory rate keeps going up. His SAT's going lower on 4 liters per minute. He's working a little harder to breathe. He's still tachycardic. He's getting hypotensive. However, his mean arterial blood pressure is still okay. It's above 65, but it's not great. And this is with fluids going at 75 milliliters an hour. So we want to make sure we're keeping his head a bit up. We want him to continue to use that IS if he can, to take some deep breaths through his nose and blow out through his mouth. Try to get him to relax a little bit. But remember, when you're hypoxic, you're going to be agitated, and we need to notify the healthcare provider immediately of what's going on, because now we really are concerned that he may be indeed getting septic. So what's your best action now as the RN? Are you going to call a code blue? You're going to call a rapid response? You're going to increasing to 6 liters per minute nasal cannula, or are you going to continue to monitor closely? If you answered B, you're correct. We'd want to call a rapid response. We'll go ahead and increase his oxygen, but probably not just to 6 liters per minute. We're now probably going to go ahead and put him on a non-rebreather at 100%. And we'll do that while we're waiting on the rapid response team to get there. We aren't going to call a code blue because he's not arresting. He has a pulse. He is alert. He's alert. He's agitated and cooperative. And he's breathing on his own. So we only call a code blue when there's cardiopulmonary arrest. We will continue to monitor him closely, but we have to do more than this because he is indeed deteriorating. After 15 minutes of oxygen therapy at 15 liters per minute via non-rebreather face mask, the respiratory therapist sees EJ's SpO2 still indicates 88 to 89% saturation. Considering his history of a ruptured appendix, his current vital signs and assessment data, lab results, which complication is most likely? Yes, he's going septic and he's probably developing acute respiratory distress syndrome. So this is going downhill fast. So now, using the SBAR format, I want you to put a call out to the healthcare provider to provide an update on EJ's condition. Remember, this is the situation, background, assessment, and recommendation. You can pause this for a moment. So what did you write? What's your situation? Our situation is we have EJ, who is a, I forgot how old he is, young 20s, young man who is currently experiencing some respiratory distress and some worsening gas exchange. And we're concerned about his going septic and going into acute respiratory distress syndrome. Background, he is 2 days post appendectomy, no significant medical history, no allergies, full code. He has had some brown drainage in his wound today. His white count's elevated. He's tachypnic, he's tachycardic, he's hypotensive. You've given the vital signs. What his white count was today at 16,000. All the cultures have been sent. He's been started on 2 broad spectrum antibiotics. The recommendation, we need to get him off this unit. He needs to either go to a progressive care unit because of our concern for sepsis and acute respiratory distress syndrome, or even possibly the intensive care unit. He's going down fast. The healthcare provider arrives, he assesses EJ and prescribes these actions. Which action should the nurse implement first? Place the patient on 5 centimeters of water CPAP ventilation at 60% FO2. Arrange to transfer the patient to the ICU. Administer nebulized albuterol every 4 hours as needed for dyspnea, or prepare for a central line insertion. Yeah, we're going to go ahead and put him on the CPAP. We can start that on the floor. We're not going to wait until we get him to ICU to put this on, because that could take a little time. The nebulizer, we can call respiratory therapy and they can get that. But I would first get him on that CPAP ventilation at 60% FO2 to make sure that he's oxygenating better and his respiratory status is more stabilized. They can put the central line in the ICU. There's nothing that we're doing right now that would require us to have a central line. We're not using vasopressors. He's still perfusing decently. So that's something they can do when he gets over to the ICU. Okay, with the initiation of the CPAP, it's at an FO2 of 60%. His oxygenation only improves slightly. He is transferred to the ICU, where he's intubated soon after transfer. List which of the following nursing actions are considered emergent, meaning they need to be done immediately, contraindicated, not indicated at this time, or non-emergent, not immediately necessary for the care of the patient. So administer 1 unit FFP for 1 hour. What would you think that is? That would be contraindicated. There is nothing here that tells us his platelets were fine. He's not actively bleeding. There isn't any reason at this point in time that he would need a unit of FFP. Before we did that, we would want to have a coagulation panel to know what his PT is and his PTT. So right now that would be contraindicated. 2, call for a chest x-ray to confirm endotracheal tube placement. That's emergent. We need to do that now. It's immediately necessary. When we raise the head of bed to 30 degrees, that's non-emergent. We will do that, but it's not immediately necessary. We can raise the head of the bed once we get everything else done. We'll do that pretty soon, but it's not emergent. Administer the enoxaparin 60 milligrams sub-Q daily. That would be non-emergent. We will do it later today. We'll get to it, but right now we want to make sure that our airway's in place and that we're breathing properly. Initiate sedation and analgesia as prescribed. That would be emergent. He was already agitated. We don't want him bucking the ventilator and fighting it. We want him relaxed. We don't want him pulling at his endotracheal tube. So we'll go ahead and initiate the sedation and analgesia as prescribed. Assist respiratory therapy and securing the endotracheal tube. That's emergent. We have to do that right now. Apply the SCDs to bilateral lower extremities. That's non-emergent. Again, we will do it, but that's something we can delegate to the tech later once everything settles down. Repeat the CBC and call the results. Again, contraindicated at this time. We can do that the next day. There's nothing there. His H&H is stable. His white count's elevated, but we just gave him 1 dose of the antibiotics, so we don't need that right now. Okay. We've got to get 1 more dose. Sorry about that. Never fails. Things ring when you're trying to get things done. Use continuous waveform capnography. Yes, we are going to do that. That is emergent. That's going to let us know about his end-tidal CO2. And again, help us know that our endotracheal tube's in the right place. And prepare for an arterial line for continuous blood pressure monitoring. This will also allow us for arterial blood gas sampling, which will be necessary while we're finding the best ventilator settings for him. But that is non-emergent. We can do that once everything else is stabilized. And then we'll get to it. Because once we intubate somebody, We're going to put the end-tidal CO2 detector on there and make sure we're in the lungs. We're going to listen bilaterally for lung sounds. We're going to watch for equal expansion of the chest as we bag them with a resuscitation bag. But we're also going to get the chest x-ray to confirm placement. That's a must. Okay. Okay. EJ's endotracheal tube is secured with the 23-centimeter mark on the tube at the level of his teeth. He's connected to a positive pressure ventilator with the following settings. His FiO2 is 70%. He's on a synchronized intermittent mandatory ventilation mode with a rate of 12 breaths per minute. This allows him to breathe over that 12 breaths per minute if he needs to breathe more than that. We don't want him getting too tachypnic though, because he's not. This will synchronize the delivery of the ventilator breaths with his breathing. So if he's too agitated or our sedation's not good, then he won't get his full tidal volume. So again, not something you're going to be held responsible for, but I wanted you to understand what we're talking about here. He's going to be on positive end expiratory, 5 centimeters of water, PEEP. And remember, the purpose of that PEEP is to improve gas exchange. Okay, it helps increase the amount of functional residual capacity, or that volume of air in the lungs at the end of expiration that can still participate in gas exchange. We have a tidal volume of 500 milliliters, and that's a good tidal volume. He can have 6 to 8 milliliters per kilogram ideal body weight is considered a good tidal volume for him. So with every breath, he's going to get a breath that's 500 milliliters. Now, if he's breathing too fast, he won't get that many. But if he's not really breathing a whole lot above the rate of 12, or he's not breathing at all over the rate of 12 that we've put into the ventilator, each one of those breaths will be 500 milliliters. His repeat blood gases show the following. Now, this is on the ventilator. His pH is 7.31. His PaO2 is 65. His PaCO2 is 48, and his bicarb's 22 with a SAT of 92%. Currently, his vital signs are 100.8. His heart rate is 106, regular, normal sinus tach. Respiratory rate's 18, so he's breathing 6 over a rate of 12 every minute, excuse me. And his blood pressure is 98/62. He's receiving a continuous infusion of propofol at 15 micrograms per kilogram per minute and morphine of 4 milligrams per hour. And this is for his sedation and pain management. So analyze his blood gas, indicate which ventilator change the RN will anticipate based on the analysis of the ABG values. So just pause for a minute and let's talk about what this shows. Okay, now he's in an uncompensated respiratory acidosis with mild hypoxia. His pH is acid. His PaO2 shows hypoxia on 70%. His PaCO2 is 48, which is acid. He's retaining CO2 now. Remember earlier he was blowing it off. Now he's retaining it. And his bicarb's 22. It still hasn't done anything. But remember, the bicarb is going to take the kidneys 3 days to do anything, and he's satting about 92%. So at this point in time, what actions need to be done at this time? Do we increase the tidal volume to 650 milliliters? Do we decrease the rate on the ventilator to 10, decrease the FiO2 to 60%, or do we increase the PEEP to 10 centimeters of water? So I'll give you a little bit of time to think about that. And the answer to that one is C. His acidosis, some of that is respiratory, but some of that may also be sepsis setting in. And his bicarb may start to fall a little bit as his condition worsens. decreasing the rate on the ventilator is not going to help. Increasing the tidal volume is just going to predispose him to barotrauma. Increasing the PEEP may decrease his mean arterial pressure too much at this point in time and might worsen his perfusion. But the big thing is, remember, oxygen is a drug, and we want to try to decrease his FO2 to 60%. With that PaO2 of PaO2 of 65 to 70 is actually okay in these patients, and that's acceptable. So we would decrease the PaO2, or excuse me, the FiO2 to 60%, repeat the blood gases, see what he's going to do. And then if we need to, we might need to go up on the PEEP a little bit if his blood pressure can manage it. But we probably wouldn't jump to 10. We'd probably just jump to 7.5 and see how he did. Might also have to give him a fluid bolus prior to doing that. The RN assists with the placement of a central venous access device for monitoring of the CVP and fluid administration, as well as the arterial line for continuous blood pressure monitoring and obtaining of blood gases. What are the preferred sites for placement of each of these methods of hemodynamic monitoring? So write those down right quick. Okay, that would be the radial is our preferred site of the arterial line. Remember, we do an Allen's test prior to doing that to ensure that we have adequate ulnar flow before we cannulate that radial artery. But this will allow for continuous blood pressure monitoring. It'll also allow us to draw blood gases without having to stick the patient. And then as far as central venous access device, we would prefer a subclavian approach. We can do right or left. Right's probably a straight shot. So the tip would be in the superior vena cava or just upon entering the right atrium. So we can look at our fluid status. And remember, for these patients, we want a CVP of about 8 to 12 millimeters of mercury because we are assuming now that he's probably septic. We could do an IJ, but the right subclavian tends to be cleaner. We want to avoid the femoral sites of it all possible because he's already got a bloodstream infection. We don't want to introduce any other bacteria into his system. So we prefer a subclavian line. A nasogastric tube is also inserted per prescription and placed to low intermittent suction. When the RN reassesses EJ, he has scattered crackles throughout his lung fields. His urine output over the past 2 hours has been 50 milliliters of clear amber urine. Valve sounds are slightly hypoactive, but audible in all 4 quadrants. The abdominal JP drainage is unchanged, and the following vital signs are obtained. Blood pressure 100/46. His heart rate's 120, normal sinus tach, regular. SpO2 is 92%. His respiratory rate is 18 breaths per minute. Remember, so he's still breathing 6 over the prescribed 12 per minute. His temperature's back up to 101.8, and his CVP is 3 millimeters of mercury. So based upon the current vital signs and assessment data, which collaborative interventions will the nurse anticipate at this time? Go ahead and select all that apply. I'll give you just a minute or two, or you can pause me. Okay, so hopefully you selected these and we'll go over each one of these. Administer a fluid bolus of 500 milliliters normal saline over 30 minutes. Yes, we definitely want to do that because we need to push his CVP up. Remember, normal is 2 to 8 millimeters of mercury, but for septic patients, which we assume he is at this point in time, he's vasodilated and his capillaries are leaking. So he's going to start to have edema in all of his tissues, not just his lungs. So we're going to lose intravascular volume. So that 500 milliliter bolus over 30 minutes is going to help push that up. Administer furosemide 40 milligrams IV push. Right now, we're not going to do that. He's already tachycardic. His mean arterial pressure is not that great right now, and calculate his mean arterial pressure. So we want to do the systolic blood pressure plus 2 times the diastolic pressure divided by 3. And what do you get? Let me see if I can get that and write it down. Dadgummit. Let me find my calculator. So we're going to say he's right at 64 millimeters of mercury. So he needs to be just a little bit higher. So we need to give him that fluid challenge and see if we can't get a better blood pressure, because we want to keep it above 65 to maintain perfusion. Start the norepinephrine infusion. We might have to, but we're not going to do it right now because the CVP is too low. Once we get a CVP 8 to 12 and he's still not maintaining a mean arterial pressure of at least 65 millimeters of mercury, then we'll start that norepinephrine infusion. And that's another reason for having a central line. Administer the diazepam 15 milligrams IV push. We're not going to do that because, first of all, that's way too much Valium, right? And we don't want to over sedate him. He's already getting morphine and propofol. There's no benefit in giving him the diazepam. It's just going to drop his mean arterial pressure more. It's also going to suppress his respiratory rate more. It's just not appropriate in any shape or form. That's a huge dose of Valium. And remember, that's going to hang around for a longer period of time. And tomorrow we're going to want to do a sedation vacation. And benzodiazepines tend to stay in the system for a lot longer period of time. And it makes it difficult to do those bedside assessments. Initiate high caloric interval of tube feedings at 20 milliliters an hour. We do want to do that. He is hypermetabolic. He is going to be burning all kinds of calories right now, and his gut's working. And if the gut works, we want to use it. And we already know that the gut plays a role in worsening of sepsis and can lead to MODS, multi-organ dysfunction syndrome. So we don't want to do that. We want to give the gut something to do. So 20 milliliters is not his goal. It's not going to meet his nutritional demands at this time, but we'll have dietary come in, tell us what his goal is going to be, and try to gradually work up to that goal. But we got to see what his gut's going to do first and if he's going to tolerate it. So we will be initiating that, and we'll be checking residuals every 4 hours. And I guess we'll use his NG tube. Not the idea, but if it's in the gut, if it's in the stomach, we can use it. Might be something we might want to call the doctor about, and maybe get a small bore feeding tube if that's available, but we'll see what he does. We want to increase his IV fluid rate to 125 milliliters an hour. That we do want to do, again, because we want to fill those pipes that are very dilated now. So we want to fill them so that if we have to start norepinephrine and we have to vasoconstrict him, we have something to squeeze. So a student nurse is assigned to the ICU that day and is preparing to suction EJ, which action by the student requires that the RN intervene immediately. A, she's increasing the FO2 to 100% for a minute before suctioning. B, she's using a closed suction technique to perform the suctioning of the endotracheal tube. C, she's performing hand hygiene and donning clean gloves. Or D, she's applying suction to the catheter while inserting it into the endotracheal tube. So which one of those answers is wrong? And if you chose D, you would be correct. We don't want to apply suction going into the endotracheal tube, only on while we're removing it or pulling back. And again, not constant suction, just intermittent suction. And we only want to stay down there about 10 to 20 seconds. One of the things I was always guilty of is holding my breath while I was suctioning them, because if I was getting short of breath, they were getting short of breath. And what you see in this picture is the closed suction technique of performing endotracheal suctioning, so that we decrease our risk of introducing any other bacteria into the lungs. We're already having a little trouble with fluid in there. We don't need to cause pneumonia on top of this. So number 19, which actions will the nurse use to decrease EJ's risk for developing ventilator-associated pneumonias? One of the things we'll talk about in class is the VAP bundle. And a bundle is something that you have to do all of these things in order to have the good outcome. You can't just pick and choose. So what are some of those things going to do? Treat this like a true and false. We want to use the lowest level of sedation and perform a sedation vacation each day. That would be true. So we're going to do that one. Change the ventilator tubing and humidifier daily. That we do not do. We only change them when they're very soiled with exudate. Otherwise, we just do it once a week because you're breaking the system. And we don't want to break the system. Every time we break the system, we increase the risk of introducing bacteria. We want to assist the client with exercises several times daily. We want to do that as tolerated because we don't want them to have muscle atrophy that could cause them to be weak and stay on the ventilator for longer periods of time. So even if it's passive range of motion, you want to do something just so that they do not have that increased weakness while on the ventilator. And eventually, what we want to do once everything's stabilized is, even if we're just dangling them on the side of the bed, getting them up to the chair, and I don't mean lifting and pulling them over. I mean, they're standing up on their feet and pivoting and sitting in the chair. And a lot of places now are doing ambulation even on the ventilator, just short distances. And we just do it a couple of times a day as their hemodynamics and oxygenation will allow. But we do want to do something. Start with passive and see how their hemodynamics do with that, how their PaO2 and their saturation are looking. And if they look like they're not tolerating it, then we quit and we make a note of it. 4, keep the head of bed elevated to at least 30 degrees. Yes, we want to do that. And 5, we want to provide oral care every shift with chlorhexidine solution. And yes, we do want to do that. Not only do we want to keep the head of bed elevated every 30 degrees, but we do want to turn them either manually every 2 hours, or if we have one of the rotating beds, we want to turn them like 20 minutes, 20 minutes, 20 minutes. So 20 minutes on the right side, then 20 minutes in the middle, 20 minutes on the left side. And if you have those specialty beds that have percussion and vibration, those should also be used a couple of times a day during the time that respiratory is giving them some of their albuterol treatments to cause the vasodilation and help mobilize secretions. Other parts of the VAP bundle include deep vein thrombosis prophylaxis, so your enoxaparin or your subQ heparin 5,000 units. We also stress ulcer prophylaxis, so another reason to feed them, but usually we're going to give them an H2 blocker, or we're going to give them a proton pump inhibitor. So now here's this x-ray. We're not going in the right direction. Fill in the blanks. So the hallmark criteria for the definition of ARDS or ARDS is known as blank blank. The chest x-ray on this slide represents the classic radiographic finding of blank seen in ARDS. So the first 2 blanks, the hallmark criteria for the definition of ARDS is known as refractory hypoxia. This means that I can keep going up and up and up and up on the FiO2, and I'm going to remain hypoxic. My PaO2 will be 65 millimeters of mercury or less. It is refractory to increase oxygenation. That's why these patients require PEEP. Remember, it's non-cardiogenic pulmonary edema. The chest x-ray on this slide does represent something we call whiteout. As you can see, all these areas that normally would be dark, black, full of air, now all of this is fluid. Some people say it looks like shattered glass as well, but we call it whiteout. All of these interventions are included in the plan of care for EJ due to sepsis and ARDS. Which of these interventions can be delegated to an experienced LPN? Select all that apply. Number 1, provide oral care every 4 hours. 2, place EJ in the prone position for 10 hours daily. 3, assess the breath sounds every 4 hours. 4, administer acetaminophen suppository 650 milligrams per rectum every 4 hours, PRN attempt greater than 101.5. 5, suction the endotracheal tube as needed. Or 6, teach the patient and family about the plan of care. So think about that for a minute. And the correct answers for this one would be 1 and 4. They can provide the oral care every 4 hours, and they can administer the Tylenol suppository. Prone position, we don't put them in there for 10 hours a day, but they may assist that, but that needs to be the RN and the respiratory therapist putting the patient in the prone position. There's too many things that could go awry. They don't assess, but especially a patient that's this acutely ill. So they want to assess the breath sounds every 4 hours. Suctioning, normally they could suction a stable patient, but this patient's very sick. We need to make sure that while we're suctioning him, that we're watching for any kind of premature ventricular contractions or signs of worsening hypoxia. We want to see how his hemodynamics are responding to this intervention. So in this case, it would need to be an RN, even though she's an experienced LPN. They might assist the RN with this, but they would not be doing this independently. And then they don't do any teaching. So it'd be the nurse who's going to teach the patient and family about what the plan of care is for every shift and every day. The nurse hears the ventilator high pressure alarm and finds that EJ appears very agitated with a respiratory rate of 36 breaths per minute. The SpO2 indicates an oxygen saturation of 81%. His cardiac monitor shows a sinus tachycardia with a rate of 142 beats per minute. Which action should the nurse take first? A, auscultate EJ's breath sounds. B, increase the FO2 setting to 100%. C, check the ventilator settings and readouts. Or D, suction EJ's endotracheal tube after hyperoxygenating him. And the correct answer for this one would be A. We want to auscultate his breath sounds because we need to know what's going on. This is something that happens suddenly. So we have to ask, is he biting the tube? Does he have a mucus plug that we need to deal with? Or is he just bucking the ventilator and we need more sedation? Or worst case scenario, and the one thing that's most likely is that he may have some barotrauma and may have developed a pneumothorax. So the only way we would know what to do though is to auscultate his breath sounds first. If he had a mucus plug, chances are we wouldn't hear as good a breath sounds on one side, but they would be present. Peak inspiratory pressure is going to go up. Peak inspiratory pressure will go up if he's biting the tube. It'll also go up if one lung collapses. But the most serious of these and the most difficult to correct would be the fact that his SATs are dropping. He's very tachypnic. He's very tachycardic. Chances are this is a complication of being on the ventilator, and he has a pneumothorax. So no breath sounds are audible over EJ's right side, and the right side of the chest does not expand with inspiration. Endotracheal tube is still at the 23 centimeter mark at the teeth. What complication of mechanical positive pressure ventilation is most likely? And like we just said, our concern is that he may be developing a pneumothorax, and that can quickly become a tension pneumothorax as the air cannot escape. And this can push everything away from. So if it's on the right side, we would see everything shifted to the left, right? As it pushes everything to the left side. Which intervention should the RN take next? Notify the healthcare provider stat, gather the equipment needed for a chest tube, offer reassurance and explanations to EJ, give the prescribed lorazepam 1 milligram, IV push, PRN, agitation. And yes, on this one, we have to notify the healthcare provider stat. And you can ask somebody for help and they can start gathering the equipment needed for a chest tube. If you've been trained, and a lot of ICU nurses and respiratory therapists are trained as to have everything to do needle decompression, the physician will, or someone will come that's been trained to do this at second intercostal space, mid-clavicular line. We can do that and put a like a extension tubing, just use an IV catheter with usually about 2 inches with extension set on it with like a 60 ml syringe, and we can decompress the chest until everything gets there. But he's going to need a chest tube, and we also need a chest x-ray to confirm that that's what's going on. Okay, since the placement of the chest tube, the nurse caring for EJ and his chest drainage system will know to perform which of the following interventions to ensure his safety. Select all that apply. And this is our last question, I believe. Since the placement, so check the chest tube dressing to ensure it's clean, dry, and intact on 3 sides. Keep EJ on bed rest and encourage shallow breaths to avoid pain. Keep the drainage system at the same level as the chest tube entry point, or strip the chest tube to dislodge any clots and ensure patency. 5, if the chest tube disconnects from the system, place the end in sterile water. 6, document the amount, color, and characteristics of drainage daily. And 7, check to ensure vigorous and continuous bubbling is in the water sealed chamber. So think about that one. And you can pause this if you need to. And the answer to this one is 5. If the chest tube disconnects from the system, place the end in sterile water. Now, the reason the first one's wrong is we want it clean, dry, and intact on all 4 sides. We want an occlusive dressing. Usually we put Vaseline gauze around the insertion site of the chest tube. We'll put the drain 4x4s around it, those that are split, right? Then we'll put 4x4s, depending on the drainage. Since this is a pneumothorax, chances are there's not going to be much drainage as if it were a hemothorax. And we'll put an occlusive tape on there. We want to keep EJ on bed rest, encourage shallow breaths to avoid pain. He does not have to be on bed rest. We can ambulate him. And we still want him to take deep breaths, because even though he will probably take shallow breaths, because it's going to hurt that every time he takes a breath because of that chest tube, but he can ambulate. We just have to keep the drainage system below the level of the chest, just like we do with a urinary drainage catheter or drainage system. We keep it below the level of the bladder. This one we keep below the chest. We don't strip chest tubes to dislodge clots and maintain patency. We don't do that. That puts too much negative pressure in the chest. We don't want to do that. We don't milk them either. So that's an absolute no-no. And he shouldn't really have any clots, because this is a pneumothorax, not a hemothorax. Like we said, we're going to do 5 until we can get a new chest drainage set up in place. 6, document the amount, color, and characteristics of the drainage daily. We'll do that every hour for the first couple of hours, and then every 2 hours for about 4 hours, and then we'll do it every 4. So we want to, every time we go in there, we'll assess the amount, the color, and characteristics of the drainage, but we're going to do it more frequently than every day. And again, he is a pneumothorax. I wouldn't expect much out, but we mark it. We put the date and our initials and the time on next to the numbers over here on the graduated areas. And then if it were a hemothorax, if you have more than 200 milliliters of drainage in 1 hour, other than the amount that you might get with initial placement of the tube, depending on the size of the hemothorax, that is too much drainage and you want to call the doctor. And then check to ensure vigorous or continuous bubbling in the water seal chamber. Remember, that's the little blue area down here. When we first put it in, when there's a pneumothorax, we are going to get this big gush of air and a lot of bubbling, but that should minimize very quickly as the lung re-expands. Now, it's not going to re-expand 100% immediately, but it should come out enough that we don't see a lot of bubbling in that water seal chamber, because that tells us we have a leak somewhere. And remember, we have the markings on there of 0 to 5. The more it goes up the number here towards the 5, the larger the air leak. So we want to check all our connections. And in these systems, you only have a connection here with this tubing, and then you have the connection at the patient. So you want to make sure that this is solid and well connected, and that where the tube is connected to the patient, that it's well taped and there's nothing there. If it continues to have vigorous bubbling, then you'd want to put a new system in and call the physician, because something else is going on. Okay, guys, that's the end. I hope this was helpful and some good practice on some of the content that we're going to be covering this week on acute respiratory failure, ARDS, and mechanical ventilation. So, and I threw chest tubes in there because, you know, we have, I think we have chest trauma during this time too. So anyway, hope you enjoyed it. If you have any questions, feel free to email me. Otherwise, I will see you in class. Thanks so much and have a great day. Bye.